What thing?
The evaluation and management of central line catheters is one of the most frequent consults that we receive from the pediatric subspecialty services at the North Carolina Children's Hospital. I have listed 2 objectives which will identify common potential complications as well as treatment strategies. Types of routinely used pediatric central devices include the peripherally inserted central catheters, or PICCs, which are inserted in the smaller peripheral veins, the longer-term tunnel catheters, such as Broviacs or Hickmans, which have a cuff that inhibits migration into the catheter tract, totally implantable portacaths, as well as umbilical catheters. Centrally placed catheter tips are associated with fewer complications than non-centrally placed catheter tips. A catheter tip with its tip ranging from the middle third of the superior vena cava to the right atrium is considered central. An umbilical catheter tip should lie in the high inferior vena cava above the level of the diaphragm. Common pediatric catheter sizes range from 1.1 French to 7 French based on age, weight, vessel size, and insertion site, type and length of prescribed therapy. Totally implantable CVCs or portacaths have a 10-fold lower risk of central line associated bloodstream infections than tunneled catheters and should be preferred whenever possible. At our facility, the smallest port is 5 French, which excludes neonates and smaller infants due to their vessel size. Central venous catheters provide reliable vascular access, facilitate painless blood sampling, and allow delivery of antibiotics, parenteral nutrition, maintenance fluids, hemodialysis, and apheresis. The complications, however, can result in serious morbidities, including emboli, SVC syndrome, iliofemoral, and IVC clots. Children require close supervision to prevent damage to their catheters from pulling or sometimes chewing. Anesthesia is necessary in this age group, but it has its own inherent risk. A recent study published in the Journal of Pediatrics by the Mayo Clinic reports that infants who undergo multiple surgical procedures before the age of 2 may show developmental problems that go beyond the risk of the procedures themselves. The procedure of placing a central venous catheter has risk related to operator experience. In one prospective cohort study, operators who had previously placed more than 50 central lines were more likely to be successful at inserting subsequent central lines with fewer of these complications. Catheter occlusion is a frequent complication. Treatment strategies first should vary on the source of the occlusion. We try to alter the patient's position, correct catheter kinks, and adjust clamps before getting an x-ray or administering a medication. Occlusions caused by precipitation can be cleared through the installation of ethanol. We use 70% hydrochloric acid or sodium bicarbonate, depending on the chemistry of the infusates. When a line is compromised by a thrombotic occlusion, alteplase or Cathflow is the only FDA-approved lytic that's approved for the restoration of catheter function. At our institution, alteplase is instilled by the nurses on the floor. When there is a withdrawal occlusion, it's instilled at a volume of 110% of the total lumen. You then wait 30 minutes and you attempt to aspirate or flush. Wait 90 more minutes if it's still not working, and at the 2-hour mark you either have a blood return or you can repeat the entire procedure. These are risk factors for thrombovenous embolisms. Approximately 2/3 of the vein thrombosis in children are associated with the use of central lines. Little information is available on management strategies or the efficacy and safety of therapeutic agents. For asymptomatic thrombosis, however, care is supportive with close monitoring of the size of the thrombus. In children with their first episode of VTE or venous thromboembolism, anticoagulant therapy is recommended. In neonates with the first VTE, anticoagulation or supportive care is indicated if extension of the thrombus occurs during this supportive care. This is one of our more frequent consults. Sometimes the lines pop or break or are leaking, and you can get a Broviac repair kit. Most of the time it is successful. I would say maybe 95% of the time. The trick is to help restrain the child and maintain your sterile technique. A true central line infection is the growth of the same organism from both a line and a peripheral sample. The colony count should be threefold greater than that generated from the peripheral blood sample. In children, we most often have coag-negative staph as the most common organism that we find. Again, CVC culture should only be performed only when bloodstream infection is suspected. Blood samples should be obtained prior to the initiation of antibiotic therapy. Skin preparation should be performed using chlorhexidine and alcohol. And again, 2 samples should be obtained. After the cultures are obtained, you can start empiric antibiotic coverage. In children, we cover gram-positive and gram-negative organisms. At our institution, we usually start vancomycin and a 3rd-generation cephalosporin, such as ceftazidime. In children, we do try to salvage the catheter as an option if the central line infection is considered uncomplicated. And when catheter salvage is the goal, such as children with short gut infection, antibiotic lock therapy has been trialed. However, the antibiotic concentrations must be increased 100 to 1,000 times to kill bacteria within the biofilm. Based on adult data, we always use chlorhexidine with alcohol now for our cutaneous antisepsis. Our children all receive a bile patch, which is a chlorhexidine impregnated catheter dressing as part of the routine dressing change. This is not to be used in premature infants, however. And we have trialed ethanol lock therapy, again at 70% for silicone central lines. This can be administered safely and may reduce the incidence of infection. The 100,000 Lives campaign is a nationwide initiative launched by the Institute of Healthcare Improvement to significantly reduce morbidity and mortality in American healthcare. Based on the successful work of healthcare providers all over the world, we are introducing proven best practices across the country to help participating hospitals extend or save as many as 100,000 lives. These are the 6 changes that are being employed nationwide, and as you can see, prevention of central line infections is part of this. In pediatrics, we have interventions or bundles which are evidence-based procedures that we know work. For example, there's a line cart, there's a nursing checklist for central line insertion, and our nurses are empowered to stop procedures if best practices are breached. So these bundles, again, are a collection of evidence-based care processes. This is an example of a central line maintenance bundle, which includes daily assessment, site care instructions, hub care instructions, prepackaged kit, as well as a training video. This is an example of a central line insertion checklist or a list of standard work before, during, and after the procedure. And does it work? Well, as you can see, it has reduced our incidence of infection on our oncology floor. Maintenance care, however, is the main driver for reducing morbidities associated with central lines. Central lines are inserted only once, but they have hundreds of episodes of maintenance care. Central line teaching tools such as this DVD reinforce clinical skills after discharge. We show the DVDs in the hospital, give them to parents to take home after discharge from the hospital. As the acuity increases in pediatric hospital admissions, it's critical to give the residents, the nurses, and the families the best information available to prevent central line morbidities. I have samples of these if anybody would like to take one back to their institution in Spanish and English, and I thank you for the opportunity to present at this meeting.